on to our next speaker, Dr. Terry Mulligan. Dr. Mulligan is clinical professor of emergency medicine at the University of Maryland School of Medicine in the United States, where he is also director of the International Emergency Medicine Program there and associate faculty of the Institute for Global Health. Dr. Mulligan is going to speak to us about critical thinking in emergency medicine.
Well, thank you very much. Thanks to the Emirates Society for inviting me back. I don't know how many times I've been back here. I think almost 20 or so in the last 15 years. And it's always very exciting for me to be here. So thank you for the invitation and for the chance to talk about this. What I think is kind of an interesting topic. How doctors, how nurses, how medical professionals think. How is it that we arrive at our decisions? When we ask emergency physicians in surveys, what do you think the most important skill is that emergency physicians or physicians provide? A lot of them answer that it's making decisions. And how is it that we actually make decisions? That's what we're going to talk about. How doctors think, how we think, how nurses think, how paramedics think, how medical professionals think. Unfortunately, in the last 20 or 25 years or so, there's been some good science available for this. So this isn't just conjecture or somebody's opinion anymore. This is some good science supporting this. I don't have any financial disclosures to make. If any of you are interested in getting in touch with me, this is my email and my Twitter. I'd be happy to give you these slides or send you information about other things if you're interested. So I want to give some thanks and acknowledgement to my friend, our colleague, Dr. Pat Crosscarry. He's an emergency physician trained in the UK, but he's been living and working in Canada for the last 30 years or so, and is arguably the world leader on medical decision making and how it affects clinical performance. And I've worked a lot with him in the last 15 years or so, teaching courses and writing about critical thinking and decision-making in emergency medicine. There are also a handful of other people who I'll show you some of their writings and some of their examples in this talk. But about 15 years or so ago, I read an article, a couple articles written by Dr. Crosscarry, but there was also a non-medical article in the New Yorker magazine that was called How Doctors Think. And it was basically about Dr. Crosscarry and his work, but also about medical decision making. How is it that we make decisions? And one of the points was that most doctors have in mind 2 or 3 different diagnoses within a couple minutes of talking to the patient. So you walk in, introduce yourself, and automatically parts of your brain are moving and coming up with ideas about what the diagnosis is. And that's true. The next question is, well, how reliable is that? So when I read this and these original articles, and they had a listing of all the different ways that we make decisions and the errors in the ways that we make decisions, I had to admit that when I was reading this list of 35 or 40 or so errors, that I had made every single one of these errors. That I had read down the list and said, yep, I've done that, I've done that, I've done that. It's just part of the medical thinking. There are now about 50 or so, they call them cognitive biases or affective biases, but these are errors in the way you think. And here's a really comprehensive slide. This shows all of them. This is 60 or so cognitive biases. And it's just basically showing you that we have shortcuts in the way we think and the way we make decisions. Shortcuts in how we should remember things, how we handle too much information, how we handle not enough meaning in the things that were presented, and how we need to act fast. And all of these are individual known cognitive biases that we all kind of experience from day to day, from time to time. And when I read through these lists, I had to admit, I've done all of these mistakes. It's kind of like, have you ever read the DSM-5? When you read through that book, this is psychiatric disorders, I read through it and go, well, that's me. Then I go to the next chapter and say, oh, that's me too. I have all of these things. Same thing with the thing about cognitive errors. It doesn't always result in a bad outcome for the patient, but I have made these different errors in thinking. So there have been some books written about this. This is Jerry Gropman, who's a doctor, but he's also a journalist. And half this book was about Dr. Crosscarry and his work, other doctors' work. This is a lay book. It was on the New York Times bestseller list for about 2 years. There's another book, the same title, but written by a nurse practitioner, a little bit more clinical, a little bit more scientific, and this was not quite as popular. But this book you may have seen recently. This is really the definitive book about this. Now, Daniel Kahneman and his partner, Amos Tversky, worked on this and won the Nobel Prize in economics based on this work, which is about 40 years of work, comes out of this new theory. And this is a great book if you really want to understand, not just in medicine, but what is the science behind thinking? And what is the science behind how we understand what's going on in the decision-making process? Most of the good hard science in the last 30 or 40 years is in this area, and this is a good book that goes over it. There's also a nice popular book about the relationship between Daniel Kahneman and Amos Tversky and how they went through this process of coming up with the science. And these are some popular books in this bookstores right now. There is also a couple different books that are about subsets of this. And this is a book by a journalist, not a scientist, a journalist named Malcolm Gladwell, who's written a number of popular books. But this book is called Blink, which is the idea of your intuitive thinking, trusting your intuition. When you're talking to the patient, within 30 seconds, 60 seconds, you get an idea of what's going on, and a lot of that is fed into your brain automatically by your intuition. And we do this all the time. The question is, how reliable is it? Sometimes it's reliable, sometimes it's not so reliable. If your intuitive thought is correct 90% of the time, that means it's wrong 10% of the time. And if you're wrong 10% of the time about an emergency patient, about their emergency condition, about a life or limb-threatening condition, then it doesn't take long for you to miss some emergencies. So there's a popular book, Blink, which is basically what is the literature that says you can trust your intuition? Versus another book that came out in response to this, saying what is the literature that says you cannot trust your intuition? You need to be analytical. You need to put the brakes on your intuition, and you need to say, okay, this is a 26-year-old male who's playing tennis and has some pain going down his arm and some sweating, and it's still there. It's probably not cardiac. That's what my intuition tells me. But I know that uncommon things happen uncommonly, so I'm going to switch over to my analytical thinking. So when do you trust your intuition? When do you trust analytical thinking? That's kind of what these two books are about. And together, the intuitive part of our decision-making, together with the analytical part of our decision-making, that's the theory, the new theory of how it is we make decisions. A lot of this was also talked about, and this is a really great book, written by emergency doctors, for emergency doctors, that talk about these exact topics that I'm talking about today, but also about how to apply that in emergency medicine. How do we apply our knowledge of medical decision-making and what's really going on in the decision-making process? How do we apply that to our protocols? How do we apply that to ED design? How do we apply that to patient throughput and some of the systems design that Dr. Wallace was just talking about? Can we wire into our emergency systems development the new knowledge of medical decision-making? So it's funny, Pat Crosscarry and Steve Schenkel, I brought together the 3 out of these 4 authors. They had never met each other, but they had written the book together. I brought them together when we were in the Netherlands teaching these courses in administration and management, patient safety, and medical decision-making back in 2005 and 6. So this is Dr. Crosscarry's latest book, just came out last year, that says all of these medical, clinical thinking errors, they ultimately funnel you down into making a diagnostic failure or a diagnostic mistake. And it turns out that diagnosis and wrong diagnosis or failed diagnosis as shown in an Institute of Medicine study from 2016, is responsible for over 100,000 deaths a year. 20 years ago, there was an Institute of Medicine study that came out that said approximately 100,000 deaths a year are due to medical error. And then 20 years later, the Institute of Medicine put out a report that said actually almost 100,000 are due just to diagnostic failure. Not medical error in total, but just to making the wrong diagnosis, about 100,000 deaths a year. Probably it's more like 300,000 or 400,000 deaths a year to medical error, all medical error. But the majority of medical error is really coming up with the wrong diagnosis. And that's what this book is about here. So, and then there are a lot of other popular books that have come out in the last 15 or 20 years. You might know Atul Gawande, who's written things about medical lists, having checklists to when you stop or start a procedure, when you stop or start a critical step. So there are lots of lay press about this. So what we've seen is this interest and science in what is the actual science behind how we make medical decisions. This sleeping giant has awoken. You know, we've spent all this time learning about the medicine, all this time studying the medicine that comes out of practice, but we hadn't really spent a lot of time looking at the thinking human brain, which it turns out is wrong about 20% of the time. So now, in the last 15 or 20 years, we're having good science based on looking into medical decision making, and this interest has awoken and is being applied all over medicine. So the key point of this talk, and I'm going to show you some kind of fun examples in the next 15 minutes or so. The best way to really show you the differences between intuitive thinking and analytical thinking is to show you examples. And I'll show you some visual examples, but I'll also give you a little bit of, word problems a little bit later. I think after you see some of these examples, you get the idea. What is the difference between intuitive thinking and analytical thinking? And you'll see it when I show you these examples. And hopefully the thesis that you'll get out of seeing all these examples is don't believe everything you think. Just because something pops into your head, just because after 2 or 3 minutes of talking to the patient, your brain delivers you what you think the diagnosis is, don't believe it all the time. And you have to know when to believe it and when not to believe it. So how is it that we actually make these decisions? Again, this book goes over about 10,000 PhDs worth of science and research that went into what is now a true science. Cognitive psychology is a true science now, which wasn't true in 1960 or 1950. And again, this book is specifically about diagnostic failure. So if you think about the brain, it doesn't just have one medical decision module. The brain, now the common theory is the brain is kind of like a Swiss Army knife that has 30 or 40 different modules, each of which comes up with problem solving in a specific way. And some of those problem solving modules are intuitive, and some of them are analytical. But when you put all of them together, you get these kind of rough division that your decision-making process is either on the intuitive side or your decision-making processes are on the analytical side. And there was a new way of kind of looking at this, and it's applied to all decision-making, but particularly in healthcare, and it's called dual process theory. This is what Kahneman called the result of the 40 years of research, and this is pretty well accepted science now in cognitive psychology, called dual process theory. And when you map out what does it actually look like, here's a map of what it looks like. No, this is a joke. Actually, I put that on there so you won't get scared. Dual process theory takes type 1 and type 2 processes. Type 1 is intuitive thinking. Type 2 is analytical thinking. And what the real diagram looks like is like this. So I'll spend a minute just kind of going over this, but don't get overwhelmed. Again, in this is about, let me go back. In this is about 10,000 PhDs of science supporting this, okay? So there's a lot of hard science. neuroanatomical imaging, psychological testing, and histology. I mean, very down to very basic science looking at this. But in general, you start over here. Where are we? Start here. Patient comes in, and you have some sort of pattern processor where you either recognize the pattern or you don't recognize the pattern. And if you recognize the pattern, and then your intuition just takes off. And it goes multiple different channels, your intuition takes off, and you come right up with the diagnosis right away. And it's very hard to stop this from happening. It happens right away. On the other hand, if you have a pattern, the patient comes in with some sort of story, not really sure what this is. It has some of the elements of this, some of the elements of that, not really sure. What you do instead is shift over into this type 2 processes, which is analytical thinking. So we always have this balance of intuitive thinking versus analytical thinking. It turns out that if you don't recognize something, and then you see it, and you see it, and you see it, and you see it, and you see it, that eventually becomes something you do recognize. And so all of a sudden, you can now, after 3, 4, 5 years of training, and you're seeing maybe 10, 20,000 emergency patients, something that you never knew what it was when you were an intern or first-year doctor, maybe after 4, 5, 6 years, now you recognize this. And you can go back and forth between these processes. Your intuition can give you an idea, and then it turns out the intuition is wrong. So then you go back to the analysis. Or the analytical thinking can be wrong, and you go, well, I thought this was going to be a heart attack, but it's not. What else could it be? And so you go back and forth between the intuitive. So I'm not going to spend too much time on that, other than to say the type 1 is almost all intuition. It's very fast. It's automatic. You don't have to think about it. Whereas the analytical thinking is, you're going to put the brakes on your intuition. This is when you say to the nurses, I'm going to order full labs, I'm going to get an EKG, I'm going to get troponins, I'm going to get an X-ray, I'm going to get blah, blah, blah. And the nurses kind of roll their eyes and say, okay. But this is where you're stopping what you think is an intuitive idea and coming up with the analytical answer. The key is you spend 95% of your life in type 1 processing, in intuitive thinking. 95% of your time, your decision making about which lane to pick while you're driving here, which way you're going to go into the office today. A lot of this is just intuitive and automatic. And it's very, very powerful. So now I'm going to give you some of these examples that hopefully show you some strength, the strength and the power of type 1 intuitive thinking. Okay, so I'm going to ask you some questions, and maybe I can ask for the lights to go down just a little bit, not all the way, but a little bit, if that's possible. But the question is, here's a horse and another horse. Here's a little baby or a child. Which of these horses is bigger? Okay, you may have seen some of these before, but here we have this horse in the foreground, horse in the background. This one looks a lot bigger because our mind is projecting this perspective, but it turns out they're the same size. They're the same size picture. This is an artificial picture that someone made on the computer. And so it looks like it's bigger, even though we know that it's not. Here's another one. Which line of these is longer? This line or this line? Well, what are the differences, right? We have these little lines here. It turns out they're the same. And if you go up there and measure it, they're the same. But they don't look the same. So your intuition, and in this case, your visual system is giving you information saying, this is the longer line, when actually it's not. Here's another one. Some of these are really, really hard to tell the difference between. So which one of these is a longer line? This big, thick black line or this one? And it turns out they're the same. They're the same length. But again, what is it that's tricking us? We're having these perspective lines that tell us to put something into the background. And when we put something in the background, we know that it's bigger, but it turns out it's not. It's an optical illusion. Another one. Which of these is the darker circle? It turns out they're all the same color. because your context of the surrounding boxes changes your perception of the center box. So you're not just opening your eyes and seeing the world the way it is. Your eyes are, and your brain is taking things in context, and it takes things in context, and then that changes the actual decision process that comes out of it. Here's another one. Which line is longer, A to B or B to C? This is kind of hard to see. Of course, we know the answer now because I've shown you 5 or 10 of these already. The answer is they're the same length, but they don't look like the same length. All right? Here's another one. I can't get my mind around this. The question is, which of these tables is the bigger table space? And it turns out they're the exact same shape. So when you have these legs in the foreground, you're kind of projecting it into the plane of the screen, whereas this one is on a different plane. And I've seen presenters before take this, they've made a little plastic transparency out of it and rotated it over. It's the exact same shape, but it doesn't look like it. What did that say? What did it say, anybody? United States Senator. Did it say United States Senator? So we have corrective mechanisms in our perception also. So we can see something that should be the way we wanted it to be, but it wasn't, and we make corrections of it also. Okay, anybody see this? Can we see anything in here? Here's kind of like a Rorschach pattern almost. It's kind of hard to see what it is, but I'll show you this picture here, and I'll show you the same picture again. Up, do you see it now? We'll go back. Go forward. You see it now? Now, can you unsee it? Can you look at this picture and not see the cow now? It's very hard. So some things, you don't know what it is until you see the answer, and then when you see the answer, you will always see the answer, which is different from some of these other ones I'll show you. What was that? Any doctor in here not know what that is? How long did I show it to you for? 0.3 seconds, something like that? But everybody knows what that is, right? Well, what is it? Shout it out. I'm sorry, it's before lunch, right? This is herpes zoster, right? Shingles. So there aren't that many things that look like this. This is a pretty pathognomonic. But imagine you were a 3rd or 4th year medical student, and you went into the room, you never saw it before, and you go, vesicles, red, swollen, seems to be like this erythematous patch, seems to be kind of in this dermatomal pattern, one side of the midline. Therefore, I deduce that it's, when you look up in the book, this is herpes zoster, right? But we know that when you have somebody who has this, there's only one thing that looks like this. What else looks like this? Maybe if they got burned by accident and it was almost just accidentally on one side of the midline, right? Or if they had some sort of contact dermatitis, but nothing else looks like this. There's not that many things in medicine, though, that only look just like themselves, pathognomonic only for themselves, right? So there's this bias against thinking, how do we actually think? How do we make decisions? We have all of the, think of all the medical school that is going into your brain, 4, 5, 6 years of medical school, right? And we study all that, histology, chemistry, biochemistry, et cetera. And then we have all of this clinical medicine coming out of here. We're studying all of that. But we only have maybe 1 shelf or 2 shelves in the medical school library of science about what's happening on the inside of here. This kind of, we just intuitively think, or we just assume that what comes out of this decision-making process is correct. How well do we make decisions? I'll show you a couple more examples of this, and then I'll wrap up. So here's another pattern. Does anybody see anything in here? Okay, you may have seen these before. So is that it? Oh, it kind of looks like that a little bit, huh? Right, here it is. Again, the same one. Is that it? The elephant going the other way. There it is again. There's a dog. Maybe that's it. And here it is again. Here's the real answer, okay? So when I go back, Can you now see where it is? It's kind of hard to unsee it once you see it. All right, there's top-down processing. Do you ever see this? Do you have any children? Do you know what Where's Waldo is? So how do you find Waldo? You go from the top and you kind of scan back and forth, scan back and forth. You're looking for his stripes. Up, there he is, right? So there's a system to doing this, looking for it. Would you apply the same system to this picture? Looking for Waldo? No, not really. You would kind of cross your eyes a little bit and look at it a little differently. We've seen some of these before. Which is the larger car? And again, these are some optical illusions. They're all the same size, but because it's being put into perspective, it's tricking us into thinking. Here's another one. This looks like a rotating spiral, like a fan blade almost, right? But it's actually not. Just keep your eye on one dot. What is each dot doing? It's not moving in circles at all. All it's doing is going up and down, but it gives you this sensation. So your brain is creating the sensation of the fan blade, even though it's not really there. Here's one. Look at this. Look at the dot. And what do you see? Do anybody see any green dot? But is there a green dot? There isn't a green dot. It's an after image left over from the way your rods and cones process color. So you're seeing it, but it's not there. Here's another one, which is the larger circle. Well, we know by now what the answer is. They're the same size, right? Here's another one. Look at the yellow dot and move your head back and forth like this. Does it look like these things are turning and moving? But they're not, okay? So you're creating a feeling of sensation, a sensation of movement when it's not there. Here's one. I know what the answer is, but I don't care how many times I know what the answer is. Every time I look at it, I cannot trick my brain into seeing it the way that what the truth is. But the question is, what is the darker circle, A or B? Okay, and we know by now the answer is, oh, they're the same color. But do they look like the same color? They just do not. What you have are a couple tricks here. You have alternating blocks. It's supposed to go light, dark, dark, light, dark, light, light, dark, light. We also have this thing causing a shadow. But when you actually do the comparison, they're the same. They're the same color. And someone went so far even as to make a real copy of this, and it still doesn't look like it. So here's something, no matter how many times I know what the answer is, it still doesn't look like that. So think about the clinical analog to this. No matter how much this guy, the numbers tell me that he's having a heart attack, I still don't believe it. Because he doesn't look like he is. Well, we have that in these analytical errors. I'll skip over this one. Okay, so here's another one. Are there any black dots? If you move your eye around, you see black dots in between, but there are actually no black dots, or only the white dots in between. Have you ever seen these as creation of it looks like movement being created? Some more optical illusions. These things are not actually turning, but they look like they are. And you have a sensation of movement when you move your head with these. So the idea is, don't trust what your senses are telling you. Your senses are not revealing the truth to you. Your senses are being changed into something else. Into something else is being affected by all sorts of things. What sometimes looks like it's going into the tunnel can now look like it's coming out of the tunnel. Something that looks like it's turning in a counterclockwise motion can also look like it's turning in a clockwise motion. Things don't always appear the way they really are. We'll skip over this one. So we can recognize these faces, but what really happens when you show them around? Same picture, but it's the right side up now. So we take shortcuts. These lines are all parallel to each other. These lines are all actually concentric circles. They're not all mixed up. And so things don't always look the way they appear. And you can be confused by things. So the point is, I don't want you to believe everything you think. What comes into your head most of the time is intuitive. Knowing the difference between trusting your intuition and shifting over into analytical thinking, that's actually what a specialist is. A specialist is not somebody who's always in intuitive thinking like that guy House on that television show. You're sick, you're sick, you're sick, go home, go home. It's not all intuition, but it's not all analysis either, because if you approach every single person analytically, the system would just grind to a halt, and we don't have the resources to do it, and it's not necessary to do that. But based on this division of intuitive thinking versus analytical thinking, what a specialist is someone who knows when to trust the intuition, when to not trust the intuition, when to shift from intuition into analytical thinking or vice versa. And that's basically from pattern recognition, which is also another word for training and experience. So that's the end of my talk. I think this is kind of fascinating stuff. I think if we have the ability to put this understanding of medical decision-making into emergency medicine development from the beginning, then we are going to be that much further ahead down the road. So thanks so much, and thanks for listening.
Well, thank you, Dr. Mulligan and Dr. Wallace, for wonderful talks. I'm getting a little nod from our organizers that it is time for lunch, and I think we've hit our time. So what I'm going to ask Dr. Wallace and Dr. Mulligan to do is to make themselves available for a few minutes after the session for any questions that you may have. And thank you all for attending, and now please enjoy your lunch.